Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. In this programme we're going to focus on men's health. We'll speak with Dr. Stephen Adams about erectile dysfunction treatments, and we'll chat to community health specialist Jan Bain from Bunbury about the Pit Stop men's health checks. But first up, we're joined by cardiologist Dr. Chris Judkins. He speaks with Rural Health West's Gay Nuttall about how to manage the risks and lifestyle factors affecting cardiovascular disease.
Hi Chris, welcome to the program. I thought we'd probably lead in with those usual risk factors and where do we start and what are we looking at when we come to weight management and smoking and family history, and what are your sort of thoughts that a GP should be really looking for?
I suppose to answer the question simply, it's all of the above really, because they're all quite important risk factors, particularly in men who may not necessarily always be the most proactive in terms of looking for assistance with those sorts of risk factors, particularly as they're often asymptomatic. But I suppose there are guidelines that really do give us some guidance in terms of how we can approach this. And generally, it's sort of males above the age of 40, we have to start thinking about looking at risk factors a little bit more aggressively, unless there's a strong family history or a prior history of heart disease. So I suppose, all of those risk factors are important. If we started with hypertension, that's a common issue in the society and particularly with men. We know that it's often undiagnosed unless it's sort of picked up. So the general recommendations are for screening for blood pressure, every couple of years under the age of 40, over the age of 40, on a yearly basis. Often, if men in particular, if they don't have a particular reason to go to the GP, they may not do that. So obviously there's got to be a bit of opportunistic sort of screening there as well. Yeah.
Obviously you would start to be looking at the other factors associated with that and starting to look at perhaps if there's a weight issue or some of those other modifications first before you sort of started to look at when you would introduce medication.
Yeah. So I suppose we take a bit of a global risk perspective these days, and we look at all the risk factors in their entirety, not a single risk factor. A male who otherwise has no other risk factors other than, say, isolated high blood pressure, mildly elevated or moderately elevated, you may obviously be a bit more cautious in terms of starting any treatment for them, and you may just definitely look at lifestyle interventions in the first instance, so diet and exercise, and if there is a bit of weight reduction as well. I suppose, and give that a good try as well. Make sure that they're on board, they're engaged, they're actively participating in that program. If their risk on a risk scale is elevated and they are unable to sort of get to target on their blood pressure, then you might think about instituting some treatment. I think we all have our own preferences for introducing treatment, but I think there are some good guidelines now in terms of what are first-line medications, how to add tablets. And I suppose my first medication to introduce is usually an ACE inhibitor, ARB if they're ACE intolerant, as a first line, possibly a calcium channel blocker. There may be other reasons why patients need to be on alternative medications, previous MI, they might be on a beta blocker, or atrial fibrillation for rate control. So there are some other reasons why you might not start with those two tablets, one of each. And then just what I generally do is increase to a moderate dose of the tablet, not going to the maximal dose, but to a moderate dose, and then introduce a second agent on top of that in combination. And you seem to get a sort of bigger bang for your buck if you do that sort of combination of the moderate dose rather than increasing to maximal doses.
To maximum before you introduce the second one.
Yeah.
And how long would you sort of probably wait while you were monitoring them before you then started to change anything if you still weren't happy? Would you wait, 3 months, 6 months?
I tend to be probably a little bit more aggressive than that.
Right.
I certainly, ongoing lifestyle can still have some impact, and certainly, weight reduction can decrease your blood pressure by 10 millimetres of mercury systolic. Exercise can sort of obtain a similar weight reduction in blood pressure. So it's important to sort of continue those sorts of modifications. So if despite all of that, single agent has not dropped their blood pressure over maybe two to 3 months, I'd be introducing another agent at that point.
Sure.
Yeah.
And then of course, we've got, the whole lipid side of it that then comes in. So obviously you'd be monitoring, cholesterol levels as well, and with that, the medications. So I guess we could talk a little bit more about, lipid management and cholesterol screening.
Yep.
So obviously it's probably a bit the same, same over 40, I would imagine, start looking at an annual sort of a review. I think there's been a little bit of talk recently in the medical discussions about, what levels we should be aiming at. What do you think?
Yeah, okay, there's the whole heap of things to discuss there, really. I suppose the first thing is just in terms of screening for men in general who may not have a history. Again, 40 is probably a good age to start thinking about screening. And we generally look at sort of not too regular screening for lipids, maybe every sort of 2, maybe even every 5 years if their previous results were pretty good. And so it doesn't have to be too often. Obviously, starting lipids, lifestyle changes, lipid treatment, I should say, with statins, lifestyle sort of modifications are obviously important first, particularly exercise, and then you might think about adding in an agent at that point. I suppose, as you correctly sort of identify, that there is some discussion about the use of statins in patients, and certainly a lot of my patients have come back with querying whether they need to be on a statin, what's their role. I think from a data point of view, we've got fantastic evidence that certain populations do definitely benefit from statins, and certain populations probably don't benefit a huge amount. So that discussion does have to be, had. So my take on it is that patients who are at high risk of heart disease, so particularly patients who've had previous MIs, previous other forms of cardiovascular disease, and those patients who are, despite other interventions, have got high lipids and meet PBS criteria, they're the sort of patients that you really want to be on a statin to decrease their risk further.
So from a total point, so are you looking at total cholesterol readings, or are you looking at the risk ratio? What do you sort of look at for a GP trying to decide, is it time now, or should we just, persevere with other, lifestyle factors for now?
Yeah, okay, so probably look at LDL more than anything really, because that's the guide, and then the risk ratio is obviously important as well. So those two in combination I think are probably the most important. Certainly you do have those patients who've got high HDL, and that can sort of skew the total cholesterol result.
I think especially now, we see so much where there has been so much, said about the statins, where patients I think are probably a little bit more asking questions and saying, do I really have to start, or whereas once upon a time it was quite simple, if your risk ratio was X and your total was, Y, then you would start.
I think it's good that the patients do ask that question, because it's an important question to ask, and certainly the lower risk sort of groups of people, and I think there's definitely, there's some argument for starting statins as primary preventatives, but I really think that unless you're a specific risk group, I don't think that's really, we don't have enough data to support that sort of approach at the moment. So,
And as a cardiologist, you're quite happy that a GP, obviously, knows their patients, is making those decisions and starts treatment. At what sort of point do you think that the GP should perhaps, make that referral to a cardiologist pre or post commencement of any medication regime?
Yeah, okay, so definitely in patients who may have a history of familial hypercholesterolemia. So, the incidence is not low, about 1 in 500 will be heterozygous for FH, in which case they almost certainly do warrant review by a cardiologist or even a specialist sort of lipid service. So I'd be referring those patients pretty soon, because we know that they all have cardiovascular events, before 30 or 40 years of age, if they're not treated aggressively. So it's quite important. And obviously, if a sort of GP does identify a possible patient, then screening for family members is important as well. And we don't have a good standardised screening program in Australia. Across the ditch in New Zealand, they do actually have a sort of a unregulated screening program where family members are contacted, and just by that simple process, you can actually identify the majority of people who do have familial hypercholesterolemia. So it's important. It's an important step. I suppose that's one group of people to definitely refer on early. The second group, I suppose, is the patients who are difficult to treat with statins. We know statins have side effects, the most common being liver upset and muscle aches and pains and increase in CK. A lot of people have muscle aches and pains that may not be related to their statins, and it's always a bit of an issue. But certainly referral to a cardiologist for a statin intolerant patient is a good idea. The difficulty with treatment for statin intolerant patients is while there are lots of other agents out there that will lower your cholesterol, they have very poor data to suggest there's actually any long-term benefit with those approaches. So you can make the numbers look very good. Are you actually improving patients' outcomes? I suppose that's the question, really.
Yeah. And for the GP in that situation where they're looking, is it time to refer and who to refer, what sort of screening or tests would you like to have had done prior to seeing the patient?
In terms of for cholesterol?
Sure.
Yeah. So, I mean, obviously a full lipid profile is important. And then I suppose if there's an issue around statin tolerance, then having a CK or some liver function test is important as well.
Right.
I wouldn't necessarily require GPs to sort of do any further testing other than those, really.
So that's pretty standard. That's fine. So for that patient, so not just the one with hypercholesteremia, if we're looking at the patient with the high risk factors where the GP is looking to refer to a cardiologist, are there any other tests, any other screenings that you would like to see? I'm sort of thinking, exercise stress test or an exercise echocardiogram, given that we're looking at patients in a rural setting?
Yeah, sure. So I suppose for the difficulty is for symptomatic and asymptomatic patients. For the asymptomatic patient, I'm not too sure that there's any great evidence that that sort of screening, even for patients who have some risk factors, necessarily derives much benefit. Certainly symptomatic patients, you want to have them screened for any sort of underlying cardiovascular disease. Those patients who are at particularly high risk, who don't have symptoms, over the age of 40, strong family history, then I think you may be able to argue that you can sort of screen those patients. In terms of screening tests for coronary artery disease, obviously they all have slightly different sensitivity and specificities. Exercise stress testing is probably the most easily available, but is probably one of the lesser tests if you have to order anything.
Sure.
So I obviously, have the advantage of getting access to stress echocardiography, and that's would be my test of preference.
Right.
In terms of stress echo, myocardial perfusion scanning, sort of nuclear scans, they all are pretty similar.
Yeah.
Okay, but stress testing by itself, just with ECG, is probably not quite as good. Obviously, if that's what you have available and you have access to, then it's a reasonable test to order. The question, I suppose, always comes down to, are you going to believe the result at the end of the day? So
Yes.
if you have a patient who's particularly low risk with symptoms that are a little bit atypical, then a stress test might provide some reassurance if it all comes back normal. If you've got sort of intermediate thoughts about whether this might be coronary artery disease, then it may just be worthwhile getting a test such as a stress echocardiogram.
Sure, and I think, for our rural patients, in some regions it's obviously available, but otherwise it's just a matter of getting organised and trying to get that done, to match in, with a visit. Often it does end up being Perth with Western Australia. I mean, sometimes we have, visiting cardiologists in some of the regions, but I think it's good to sort of know, and even be able to give the patient the option. We can do this. You still may need to go on and do something else, depending on what the cardiologist thinks.
Yeah.
But the other thing that comes to mind, of course, is the patient with diabetes, type 2 diabetes, which obviously then adds to the story overall from a cardiovascular point of view, but also from all of those risk factors and the general management.
Yeah, so diabetes is obviously of increased incidence in our population. There's some old data from a good decade ago now which looked at incidence in the general population, and for every diagnosed diabetic there's about one person who was undiagnosed.
Sure.
So there's a lot of sort of undiagnosed diabetes out there in the community. So it's worth screening for that, and particularly for people who might have a bit of excess weight on board, who certainly have other risk factors as well. It's important to screen for that. I suppose once people have diabetes, whilst we can control sugars, it's definitely better to pick up people in the pre-diabetes stage.
Yeah, absolutely.
Yeah, so I think, and I sort of, my male patients, I stress that to them, that if we've picked up a bit of borderline sugar, this is the time to act and to reverse that before you get diabetes, in which case it's a lot harder to manage and the outcomes are definitely worse.
So in that annual screening, that fasting blood sugar is an important one to add into the mix, which everybody does, I'm sure, but definitely worth keeping in mind. And then, of course, the issue, if you have got a type 2 diabetic, who's been commenced on, some medication. Are there any then thoughts when it comes to antihypertensives or any of the statins when you're coming to add into a medication regime?
Yeah, I suppose there's a couple of issues there. I suppose it depends if they've got any underlying kidney impairment as well. If it's mild, then you might think about an ACE inhibitor or an ARB as an option there. Obviously, avoiding too high doses in patients who may have, more severe renal impairment. There is a small amount of data looking at statins that suggests there may be a slightly increased risk of diabetes. However, I think that's sort of at the moment a little inconclusive, and probably I would reassure my patients that that managing cholesterol appropriately with a statin is going to derive them a lot more benefit than any potential risk with the diabetes from the statins. Yeah, and then in terms of managing diabetes itself, well, again, it's lifestyle. We come back to that again. It's important, and then obviously commencement of medications that might be appropriate to them. Yeah.
And having just mentioned those lifestyle factors, which of course is the thing where it comes back to, do you have any tips on brief interventions that you think work better than others when it comes to trying to get patients, especially men, to take a bit more notice, perhaps?
Yeah, I think getting buy-in from the men is important, because these are they're often asymptomatic. They have a risk factor. They don't necessarily derive any obvious benefit from doing lifestyle changes and these things. So I think having buy-in is important, and my approach really is to identify really what's concerning them most. A lot of men will come in with one particular issue. My blood pressure's a bit high, my cholesterol, I really don't like this cholesterol result. And I tend to focus on that particular risk factor initially in order to get some buy-in and say, hey, look, we can do something about this, and then might focus on other risk factors once they've seen that there's some benefit from doing that. And the way to do that, I think, if we use blood pressure as example, if you can reduce your systolic blood pressure by 10 millimetres of mercury, or diastolic by 5, you can derive a huge sort of cardiovascular event benefit from that. You can decrease your risk of heart attack by about 20% and stroke by about 40%. And so I let my patients know that this is the benefit you can derive from just lowering your blood pressure. And then blood pressure is one of those things that you can measure, so they can get continuous measurement. They can see how they're going and see that, oh yes, I'm actually deriving some benefit from this, rather than it just being a number, really.
And you give your patients a target and encourage them to check their blood pressure regularly. Because I think sometimes, yes, if you've got a target and numbers, something to focus on, I think particularly with men, it gives them something to aim towards.
Yeah, some motivation. Yeah.
Yes.
So we usually sort of identify a target to get them to, based on their overall global cardiovascular risk, and sort of say, let's aim for this target. And up front, I'll usually let them know, based on where they are with their blood pressure when we start, how many tablets they're going to be on, what this is going to take. It's not, if their blood pressure is 160 and we're aiming for a target of 140 or below, they're going to be on a couple of tablets. Okay, that's, I try to be upfront with them and say, look, we'll start this tablet, see how we go. We're probably going to have to add another tablet in, but it's a slow process, And the other thing that you can sort of intervene there with is sort of, if you sort of can engage in some lifestyle change, we may be able to keep it to one tablet. We may be able to derive benefit from those lifestyle changes, and that's often a good motivator as well.
Sure. And what about the questions that perhaps come up from your patients when it comes to the side effects? Because I think, the general media does talk a lot about, and not just the statins that we've already talked about, but general side effects of some of the cardiovascular treatments.
Yeah. So it's always a bit of a tricky one, because everybody has a side effect of some form or other.
Yes.
So, and it's difficult to sort of tease out if it's a real side effect or if it's just one of those things. We all have aches and pains, and so it's not necessarily statin related myopathy. So, I sort of try to tease out if this is definitely a side effect or if it's not. If there's any concern from the patient, they're not going to be compliant with the medication, then you change. Because you have to have the patients on board agreeing that this is the right thing to be doing. So in terms of specifics, I think the common side effects are common with most of the medications, which we sort of recognise, and we've covered a few already. And if there's a side effect, we can often try another agent in the same class. Alternatively, go to a different class.
Good. And I suppose, we've been talking about, the different medications. Another thing that's been in the general media as well as the medical media is the aspirin debate. And whereas, you know, a few years ago it was a standard, what are your thoughts on that now?
Yeah, sure. So secondary prevention, so anybody who's got cardiovascular disease, you know, 25% risk reduction on aspirin to prevent a recurrent event. So
Sure.
secondary prevention, aspirin is absolutely essential, and any of my patients who have had heart attacks or even who have had sort of interventions, stenting or otherwise for atherosclerosis, then I'll have them on aspirin and recommend it lifelong.
Right.
And you obviously do things to try to avoid any gastric upset, you know, coated aspirins and with food and those sorts of things. That's important. In terms of primary prevention, I think this landscape's changed a little bit, and a lot of people are on aspirin, you know, just in case. But the reality is, from lots of trials and large numbers of patients, that you really need an absolute sort of 3 to 4% annual risk of a cardiovascular event to derive benefit from aspirin as a primary preventative.
Yes.
And most people don't sit in that category. So I wouldn't recommend it routinely to patients. The landscape may change on that. So obviously there probably is a group of people in there who do derive some benefit, and there are some studies looking at, you know, LPA genes and these sorts of things where you've got modified alleles, and these patients may, at higher risk of cardiovascular disease, and they may benefit. But so the landscape may change on this over time. But as a whole, across the general population, primary prevention, probably wouldn't use aspirin.
Right. I think that's very clear. Thank you. That's good. So following on from the secondary prevention and your, you know, recommendation to include aspirin there, as a general GP management for post-MI. So those patients that have either been treated at a regional centre or have been sent to Perth from their rural location and then returning home post-MI, sometimes the information is not so clear, or it might not follow the patient directly. What are your standard recommendations post-MI?
Okay, well, the first thing is to get good communication out. I suppose that is essential, because, you know, often patients will be catching up with their GP in the first week or two after they discharge from hospital. If it's been an MI or a stenting procedure, obviously communication is very important. And I'd encourage GPs to call the cardiologist as well, because generally speaking, we're sort of interested in hearing and making sure that patients are on the right treatments. So obviously, you know, make a phone call or whatever, it's fine. I suppose the second thing would be, in terms of standing orders, I suppose, it depends on if patients have come in, if they've had an acute coronary syndrome or not, if they have ongoing medical therapy, if they've had stenting procedures, or if they've had bypass grafts. So all of those patients, I suppose, end up on slightly different treatment paths. Standard aspirin for all of those all those patients, and statin as well. Okay,
Sure.
So both of those are really the key treatment options. Beta blockers in the setting of an acute coronary syndrome, certainly for probably 12 months. Longer than that, I don't think we have any data. So, you know, can continue, may want to stop. After stenting and bypass grafts, data is probably not quite as strong for beta blockers, and often they will be stopped as long as there's no other reason for them to be on those medications. That's probably really the main two, the aspirin and the statin, and then obviously adherence to treatments for other risk factors to prevent any recurrent events is key.
And what about physical activity? Because I know, you know, it still does come up as a question. It's not something that's probably so focused on now, but what would your general recommendations be for reintroducing people back to the standard of physical activity that they may have been doing, given that we may be talking about people working in the mining industry or farmers who probably, you know, do work quite long hours and long days? Yeah.
I suppose it has to be graduated, really. If they've had bypass grafts, they may have a bit of deconditioning from their hospital stay. So this needs to be a bit of a slowish process. I always recommend to patients, particularly men, that they are the best judge of what they can and can't do, but they actually need to listen to their bodies and actually act on whatever their bodies are telling them, and not just go back to what they were doing previously at full tilt. And, you know, it's the typical example of the 40-year-old who goes to the gym, hasn't been to the gym since they were 20, but they still think they're 20. And I use that analogy sometimes with my patients to say, look, just take it a bit easy, you know, take it a bit slow, and just slowly increase your activity, and you know, if they've been revascularised completely, and as long as they don't have any major heart failure secondary to their event, then they really should be able to slowly build up their activity and get back to what they were doing, and all those sorts of things that they'd like to do. But it does take a bit of time, and certainly for people who are working, have got work commitments, and may have limited supports, then they need to really have a bit of a think about how they can maintain their commitments but not put themselves in a position where they might be compromising their care and their health. Really.
Yeah. Thank you very much.
No problem, it's quite a pleasure.
Now, we all know that men can be pretty blasé about going to the doctors, especially in the country where there's a bit of a she'll be right attitude. Well, the Pit Stop program has been designed to make health checks for men quick, easy and accessible. Jan Bain has run 11 pit stops in Bunbury, and she spoke with us about how the program works and the benefits she thinks it's had for the men in her community.
When we first started to think about how we were going to do this, I think we were aware that we didn't actually provide a program for men, and some of the men in the community were saying community health doesn't provide any service for men, you focus on women. And basically, yes, that was right, because men wouldn't come. So when we actually looked at, yes, we do need to provide a program for men that they will come to. We had a meeting with quite a few of the different stakeholders in the area, such as Heart Foundation, HAC, Milligan, Friends of Community Health. It was quite a range of people who we met with, the RSL and DVA. And what we came up with was we actually needed to go where the blokes were, not expect them to come to us. So one of the members of the committee suggested that maybe we should go to Bunnings. And being a private enterprise, we wondered how that was going to work. So somebody from the committee actually approached Bunnings, and they were very happy to accommodate us. And since then, we've been running them at Bunnings every year. I'm just going to do your chassis check now. Yeah, sure. So if you'd like to stand up, and I've got this great big, enormous... So Pit Stop is to try and raise awareness for men to take more care of their own health. So because they look after their cars very well, they don't necessarily look after themselves very well. So that's why they devised the Pit Stop program. It coincides with car parts and different things that cars do. So there's the chassis check, and that's your waist measurement. And then there's oil pressure, which is blood pressure, and wheel balance. So the wheel wobble, that's balance. And then the extractor, which is bowel cancer, and fuel additives, which is alcohol, and the grill, which is their dental health. We added that one because we had the dental nurses who were keen to come to this program. So we sat down, we thought, well, what is it that a car's got like teeth that we can use? And so we came up with a grill. Duco, which is the skin cancer. Spark plugs, that's testicular cancer, and that's for blokes under 45. Fuel injectors is prostate management for blokes over 45. So the exhaust is smoking. And the shock absorbers, which is their emotional health as well. So the idea is that they get a work order. So it's like taking your car to a service station, okay, to have a service. So you get this, and then you go around to each station and get the car checked yourself. And at each station, they actually just get assessed on that station. Once they've been through the whole thing, then they go to the main table, which is the head mechanics, and the head mechanics then go through the car and say what needs to be done and what doesn't need to be done. So getting the whole picture rather than sort of at each station, because it's the whole picture that we're really looking at. Then from that, depending on the amount of things that you have not quite right, you get a roadworthy or a work order. So we give them if they get roadworthy, they get a blue sticker. If they're not roadworthy, they get a work order, which is a yellow sticker. So it's again that comparison with, okay, you take your car to be serviced, but you don't take yourselves. They can come through this, they can see that there might be a couple of things wrong, they might get the work order, and we recommend that they actually go to their doctors and have it checked out, or go, If you get a yellow sticker, you've got a work order, you need to do something about it. So going through all of this, we recommend that you go and visit your doctor and make an appointment as soon as you can. So I'm actually going to give you a yellow sticker so you are not roadworthy. And I certainly advise that you go to your doctor. It does take about 20 minutes for them to go through the whole routine. And that's because we do that, the 9 stations. And because I think that's just the way that we've decided works best for us. And it's also so because we've got the Cancer Foundation, Heart Foundation and different other organisations working with us, and the dental nurses as well. So we've sort of got our station set up to suit the people who are involved. The other thing that's really important is that men feel safe, secure and interested. So it's an open venue. We don't actually have health notices of any sort. It's cars and things like that. So that we used to have an old FJ Holden that was there, so that sort of brought them over. Occasionally we've had a motorbike or something like that, so that they brings them over and they can see what's going on. So what we often do is just pounce on them as they come in the door. We usually have somebody who's quite vibrant with our flyers and whatnot and say, come and have your health checked. It's interesting the stories that you get from them. Some say, I'm too busy. Well, this is only going to take a few minutes. It's interesting because a lot of them put up a defence and say, no, they're not going to come. And they do, which is great. So on the actual day, it's all systems go. Well, the day before it's all systems go as well, because we usually go and set it all up. And we have the Bunnings staff helping to move furniture and all the rest of it to give us the space to set this up. So it's all set up, ready for first thing in the morning, and it's just a happy event. I think every year is different. It's just a little bit different each time. We started off because we did it in Seniors Week, so we got a lot of seniors, and now we're getting younger blokes coming through, which is great as well. So because each year is different, and we've also got different people working with us, I just think it's exciting because it's not, we sort of anticipate this is how the day's going to be, but often it doesn't turn out like that. It's better.
I have before, but not for a while.
Okay, is it okay?
As far as I know, yeah.
We actually do spend a fair bit of money on flyers, and we give the flyers out to different people, and word of mouth we try and tell people what's going on. There's community announcements, we sometimes have people on the radio talking about it, but by far it's the people who are just happening to be in Bunnings on that day, and they're the people who we normally wouldn't get to access our service. So they're just ordinary people who've come in to do a bit of shopping, and I think the last time that we did the stats, it was at about 80% of the people who came through were just the shoppers. They didn't know that they were coming for a health check, but because blokes hate waiting, and if there is a bit of a queue at one of the stations, we've got our different drinks, so the standard drinks, and we have a jug with pretend beer in it. And they have to actually pour what they think a standard drink is, which is very interesting. So we've got a wine glass and a beer glass, so they need to sort of work that out. So that then sort of creates a bit of interest so that they don't mind so much that they're actually waiting. Okay. How many standard drinks do you have on a typical day when you're drinking?
5 or 6.
I do think there's a lot more blokes out there who actually do go to the doctor. I think that's improved over the last 13 years. I'm not sure whether pit stops had an effect on that, but I just think that there is an awareness out there with blokes now that you actually can go to the doctor and you're not, it's fine. For checkups, you don't have to necessarily have something wrong with you before you go. And I think that just from the feedback that we've had from the groups, that everybody who comes along enjoys it and does take notice and changes their lifestyle a bit as well. So I just think it's great. Okay, so I'm just going to give you that. And I'm going to get this ready for you. Okay, thank you.
Thank you.
Bye.
There's continuing debate about PSA testing and the level of benefit derived from screening for prostate disease. We recently caught up with urologist Dr. Jeff Thavasilan, who sits on the board of directors for the Urology Society of Australasia, to get an update on current recommendations regarding PSA screening and the treatment of prostate cancer.
Jeff, thanks for joining us.
You're welcome. Yeah.
PSA testing, the debate around PSA testing has
Sure.
been around for a while now. Can you just give us an update on where we're at with its value?
Yeah, look, I thought it may be worthwhile just going back to the basics, because I think we get very much caught up in the PSA debate, and I don't think people realise why we started using PSA. And the reality, prostate-specific antigen, it is a test that we use for diagnosis of prostate cancer, but the debate came about because it's not a great test. We know that we all accept it. It's got a high false positive rate and a relatively high false negative rate. So, but the question is, do we have anything better at the moment? And there are a few tests sort of available, not on rebate, and we'll talk about that later, but this is the best test we have in terms of prostate cancer. So the question is, do we use it or not? And the debate then goes into the area of screening, and I think that's where a lot of people get confused. So we all agree there's lots of controversies, from the GP college to the Urology Society to American Urological Society, NHMRC has a different policy and different attitude towards it. But the bottom line is we all kind of agree there's not enough evidence to screen. So we don't put PSA on the end of cholesterol, triglycerides, BSL, blood sugars. It's not a screening tool. But we do agree that it's the only test at the moment that can look for prostate cancer, and we should use it in a shared decision making. So, meaning informed consent, tell them what the test is about, and then make a decision whether you're going to be tested or not. So if you take that attitude, then the next step is, well, who do we test? Okay. There's been a couple of big randomised control trials from Europe and the States looking at prostate screening, and there's not a lot of evidence for screening, as I said, but it did show in one of the trials, between the age of 55 and 69, if you have a PSA test and found to have prostate cancer, your survival actually improves after about 8 to 9 years when you're looking at that time frame. And so the curves sort of start to separate. So there's definitely an advantage in shared decision making and PSA testing from 55 onwards up to the age of 69. How often do we do it? NHMRC's, AUA guidelines suggest every couple of years. We do it annually, and there's a policy out by the Urology Society of Australasia which at the moment suggests we do it yearly. But again, that's sort of up for debate.
So the reason you then specify a top end of 69 is because the benefit that might be derived obviously tails off as the age.
As the age, there's an increase in prostate cancer diagnosis, but the likelihood prostate cancer is going to affect your lifespan, longevity decreases. So obviously if you have a 75-year-old who runs marathons, going to live for the next 10, 15 years, his father's still alive at 95, you treat him as you would a 65-year-old.
Sure.
Similarly, if you have a 65-year-old who has ischemic heart disease, diabetes, emphysema,
you might treat him as you would
Yeah,
a 70-year-old.
70. So you've got to take that into context. So it's not cut and dry.
But essentially the short answer then is every 2 years, possibly every year.
Yeah,
Between about
we
50.
generally suggest every year here.
Yep.
And with that goes the digital rectal examination. Okay, so a lot of people just do the PSA, but you're going to miss a few cancers if you don't examine, because PSA is not, as I said, the best test, and some cancers you'll feel and you won't have on a test. And the other group is under 55. Okay, so they're the group I think benefit from having a PSA test, because they're the ones who are going to lose from dying early.
Yeah.
The problem is not a lot of them get prostate cancer, so you're going to have to diagnose, or you're going to have to biopsy a lot of men to get one and treat them before you actually save one. But that's also the group that if you miss a prostate cancer, it has a devastating effect.
Yeah, the greatest impact.
Yeah. So what we actually say, the Urology Society has a stance on it saying we recommend a test at the age of 40, okay? And we stratify the risk of that patient. So you have a range of PSAs for 40 to 50, it's up to 2.5, and a median is about 5.6. If you're below that median, your risk of prostate cancer is very low. And you could say, come back in 5 years or 10 years to have another test. If your PSA is above the median, then your risk is significantly high, and you might say, actually, I'm going to check you in 2 years, 1 year, 2 years, 3 years. If you had a family history, you're significantly high risk, and you might check them on a yearly basis. So you can stratify someone's risk early on from the age of 40. I've just operated in the last 6 months on 3 guys, one age 41 and 2 age 42. Both, 2 of them had family history and 1 didn't.
So again, we're not talking about the screening in general, but we are talking about using a good history to create some targeted screening.
Yeah, so we agree that screening, just saying we'll do your 6 monthly blood test and add PSA on, we agree that's not really acceptable.
Yep.
But there needs to be an offer of doing the PSA, the implication of what PSA is and what treatments can be offered, and then deciding, yes, the patient says, yes, I want to be checked, and continue with a program of testing. So I think that's a little bit different to, people get caught up in the controversy about PSA, that a lot of the controversy is about screening and the benefits.
The trick is then to target the right people.
Yeah, target the right people. Yeah.
So then you mentioned some other tests.
Yeah.
What else is there?
So at the moment there's 2 tests out on the market. One's called PCA3, which is a urine test. So to get it, it's a bit awkward. You've got to actually massage the prostate, the rectal examination, massage it. They get the initial urine collection and sent off, and they analyse it. Another one is called a prostate health index, PHI test. At the moment, I think they're done by Clinipath, and they're not rebatable, so the patient has to pay. But they have been shown so far to be potentially a bit more accurate than what PSA is. They do use the prostate health index, uses PSA and use a formula to derive the numbers, and they put you at a high risk, intermediate risk or low risk of prostate cancer. So it's just adding a little bit more sensitivity to PSA testing, and whether you should further evaluate people for prostate cancer. It's not available as yet as a rebate. So I'm certainly started using it in select cases, but I don't think it's something that everyone should be suggesting to use it on a regular basis out in general practice.
Okay, can I just then move on to talking about some of the actual treatments for prostate disease? And I've heard people talking about robotic prostatectomy.
Sure.
What is that?
Okay. So I suppose stepping back, if you have prostate cancer and it's localised to the prostate, and we can treat it, cure it, get rid of it, or try to, the 2 options are the radiation in general, and there are various types, or surgery. Now surgery is basically removing the whole prostate, the urethra, which is within the prostate, seminal vesicle, which holds the seminal fluid, out, and then the bladder joins the rest of the urethra. Now, it's like getting from point A to point B by a car. You can go in a Mercedes, you can go in a Hyundai, you'd still get to point B. So robotic is just another technique. So we can do the surgery doing a cut that's open, radical prostatectomy. We can use telescopic procedures, so laparoscopic radical prostatectomy, or robotic assisted laparoscopic prostatectomy. So the difference is with a telescope, where we physically put an instrument into the body, we physically hold that instrument. We can move it up and down and change it and do whatever. With the robotic, it's a robotic arm that goes in.
Yep.
The movement is at the wrist of the robotic arm. So the number of degrees of movement is much greater. We sit at a console to control it. And if I do this movement, the robotic arm does that. So basically it's a lot more greater degrees of movement. It mimics what your hand does. The telescope is 3D, so you feel, and 10 times magnified. So you feel like you're sitting in someone's body operating. So the magnification's great, and the manoeuvrability is fantastic. Then you get the advantage of doing it like a laparoscope. You have the minimal incisions. But what's got to be recognised is whether you do it open, standard laparoscopic or robotic, essentially the outcome in the long term in terms of cancer outcome, continence, which is one of the major issues, and erectile dysfunction is similar.
So there's no advantage to some of those major complications.
There are things that are going to change, and there's going to be more data coming out, and there is some information coming out saying maybe the outcome from robotics is better than open or things like that. But the reality is, when you look around, there are some surgeons who do open, some surgeons who do lap, some surgeons who do robotic. If one was absolutely superior, forgetting the cost associated with robotic, there'll be a real push for everyone to use it. The health department will be onto it, and we'll be all using robotic. The reality is you can have a good open surgeon who can produce as good a result as a robotic surgeon. The instrument doesn't make a bad surgeon better.
Yeah.
It's purely an instrument.
So you've talked about the different surgery options, but does laser have a place in the treatment of prostate cancer?
No. Laser's only for benign, non-cancerous disease. So benign prostatic hyperplasia, which causes, your flow's slow and you get up at night and you can't pee. So we're just making a channel using a laser so you can pee better. That's basically it. It's not a cancer treatment.
In terms of those complications, incontinence and erectile dysfunction in particular, those things that can make an enormous difference to someone's quality of life.
Yeah.
Where are we going? Is there anything on the horizon that may be more protective?
In terms of prevention, I think certainly in terms of technique of surgery, we are learning a lot more on how to preserve the sphincteric area, how to preserve the nerves, what precautions we need to take. We know there's information on the advantage of physiotherapy early, prior to having your prostate taken out, being an advantage in terms of regaining continence early on. We do what's called penile rehabilitation, stimulate the penis with the equivalent of Viagra early on, well before the radical prostatectomy, and continue that afterwards to stimulate blood flow and so forth. But it's controversial whether it helps or not. So technique isn't changing, and what we do around the procedure is changing. Is there anything new sort of in terms of instruments or procedures? Probably not. I mean, I think it's just people's experience are getting better, and the way we're looking after it is getting better. And certainly there are treatments that we can offer afterwards to accommodate for it. And the reality is, incontinence in men is probably more common than we think. Most surgeons will quote probably under 5% incontinence rate at 12 months. If we sent out a questionnaire to the community and said, are you having any leakage? You probably get response of about 30-40%, because what we may say is fine is different to a patient goes, well, actually, I do leak occasionally. It's not what like it used to be, but you know.
Yep.
So the degree of leakage varies, and it's probably more common than we think.
So what are your options then for management of incontinence?
So after any prostate cancer treatment, whether it be radiation surgery, there's obviously a risk of incontinence. We know that most of these patients will improve over 12 months, so we don't hurry into treatment. We do know physiotherapy helps, so we certainly encourage them to see a pelvic physiotherapist, so someone who's dedicated in that area, not your general physiotherapist, and get them doing pelvic floor exercises akin to going and doing muscle building with a personal trainer. Really, they've got to be dedicated, and you've got to do it probably 6 months to notice an effect. Now, if it's still an issue at 12 months, then there are surgical options, and very much like what we do in females with slings, there are various, it's probably about 5 or 6 products out on the market. It's a booming industry now, from slings to artificial sphincters, certain balloons we can put in, and we need to work out how much it bothers the patient, to what their bladder's like, what their sphincter's like, and get the correct sort of device to fit them. And they have a reasonable success rate. We can't guarantee it's going to get anyone completely dry, but it certainly is successful in getting someone down to wearing maybe a security pad because they might just have a drop or here or there. So there are options in the long term, and yeah, unfortunately there are a lot of men out there who haven't seen physician,
Haven't sought
treatment, thinking, well, we can't do anything about
Well,
it.
as you said, that how much it affects each individual seems to be hugely variable.
Yeah,
there are some
absolutely.
people who are
Yeah.
find it quite horrific to have any leakage at all, and some people who seem to be quite tolerant of quite extreme incontinence.
Yeah, I mean, I see a lot of these patients, and they get referred for surgical intervention, and from other colleagues of mine, and you sit down and talk to them, and it's variable. There could be someone who leaks when he, plays table tennis. That's it, and he wants something done. It's devastating. And there are other men. I've got someone who leaks, wears 3 pads a day. He flies internationally. He's busy. He goes, oh, really? I can cope with it. I don't have time for anything else. I'm used to it. So we treat according to what their expectations are. And what they want to do, really, because it's now beyond cancer treatment, it's quality of life and everything else. Absolutely.
Well, finally for this program, we spoke with sexual health physician Dr. Stephen Adams about erectile dysfunction and the various interventions that are currently available.
Stephen, welcome to the program.
Pleasure.
In terms of erectile dysfunction, we've got at one end, in terms of treatment, the basic lifestyle interventions, and we've got at the other end some fairly complicated surgical interventions. Can you just talk us through what treatments are in between those two extremes, and at what point we might start to consider each of those treatments?
I suppose if we start with the presentation, how you take a history determines to a certain extent your diagnosis. Whether, for example, you think it's performance anxiety, if it's a problem that's sometimes there and sometimes not, as opposed to the other extreme where somebody's coming with a definite medical condition like diabetes or prostate cancer, where you know they've got a permanent problem. So partly it's degree of severity of the condition, partly it's how long it's been there, whether it's consistent or variable. Lifestyle modification is interesting because, for example, compared to general practice, if a man comes with erectile dysfunction, I have much greater success persuading him to give up smoking or exercise or lose weight, because there is evidence that can help things, and it's something very important to men, so they're actually prepared to make those change. And I think we always need to integrate that into our treatment, whatever else we're doing. The other thing I would also always do is the sort of psychological aspects of it, because the days when we used to divide psychological from physical to a certain extent have gone, because it's almost impossible to have an erectile dysfunction without it having psychological consequences. So psychological support, explanations, involving the partner if there is a partner. All of these things are important in addition to the primary treatment. Okay. Choice-wise, I suppose first-line treatment nowadays, other than simple lifestyle or reassurance and so on, is probably the tablets. We have three. We have Viagra, Levitra and Cialis. And Cialis is available in a pre-sex dose or an everyday dose, the new 5 milligram dose. So there is a choice between those three drugs. In terms of choosing, there is great interpatient variety, so variation. So, for example, statistically, they're all as good as each other, but as an individual man, you may get bad side effects with one, not at all with the other, or one may work and the other one doesn't. So with a few exceptions, I will usually ask patients to try all three and choose which one suits them best. The exceptions I would talk about would be younger men with psychological performance anxiety. I find that using a drug pre-sex can sometimes increase the amount of anxiety. You know, should I take the tablet? Is it working yet? Is the one I took yesterday still working? All that sort of thing. So taking an everyday or an every second day dose of a longer acting agent such as Cialis, tadalafil separates out the taking of the medication from the act, and that can actually be a very helpful intervention. So that would be an example of me choosing as opposed to the patient choosing.
So if you don't get an adequate response, or if the patient isn't happy with the response on the pills, what's the next step or the next intervention that you'd consider?
The choice to go to an injection, mainly because the tablets don't work, to be honest. The tablets in general work in about 80% of men, but in diabetics and following prostate cancer surgery, it drops right down to about 35-40%. So in those men in which case the nerves are damaged and the message is not getting through, the drugs which essentially act as an amplifier in the penis can't work. And so therefore they may try them, and either I might try them or they may have already been tried by their GP. They don't work. The next line of treatment would be penile injection treatment for most men. An example of that would be, I see about 6 new patients a week following prostate cancer surgery, and they all have erectile dysfunction. It's very unusual for the tablets to work. It's very important that they have erections as part of penile rehabilitation to keep the penis healthy and to encourage the regrowth of the nerves, if you like. So we get them using penile injections on a regular basis. Other men have severe erectile dysfunction, tablets don't work, or in diabetes again, they don't work either. So penile injections have been around for a very long time, many years before Viagra, and we still use them in a significant number of patients, and they sort of remain the gold standard, I suppose, for treatment.
And how are they received?
I think a lot of it's how they're sold. I think if you give adequate explanation and reassurance, and if you explain that there are many different injections and combinations of drugs that we use, and that some of the things they may read online, for example, about priapism and about scarring and about pain and so on, are very, very rare side effects, and the vast majority of people do get on very well with the injections. But it's statistically only about 50 to 60% of men who use injections are, when asked the question, are you happy or satisfied with the treatment, will answer yes. And I think it's just the nature of the beast of actually sticking a needle in your penis is not a thing you'd choose to do unless you absolutely had to. But we have many, many people who use it regularly and continue to use it.
So at what point then would you start to consider, or in what patients would you start to consider a more permanent solution, some of the surgical solution?
Well, permanent is the important point. If you're considering surgery, then that is a one-way step. So therefore, you have to have tried everything else, and also you have to be sure that the condition you're treating, the erectile dysfunction, is a permanent problem. So going back to our example following prostate surgery, improvement can expect up to 2 or 3 years after surgery. So we would never refer somebody off during that time, or very rarely anyway, because there's a chance of improvement. But if at 3 years post-surgery there's nothing happening, they either can't get on with the injections or they hate using them or whatever, then sure. Diabetic, younger diabetic maybe, age 45, who has severe erectile dysfunction, is not going to get better, the other treatments don't work or are unsatisfactory, again, refer off for surgery. And so I probably refer about 1 person a month off to have penile implant surgery. And the studies show that 90% of people who have surgery are happy with their treatment. So again, it's acceptable. But it's not easy to get, and it's very expensive. I mean, even if you've got private health insurance, you're still out of pocket by $2,000 or $3,000. So it's not a thing that everybody can go for, and it's not available through the public hospital system.
And do the devices have a lifespan?
Well, the newer ones are supposed to be guaranteed for life, meaning that if they break down, they will be replaced. But it's a bit like any other prosthesis. I mean, they're not expected, ideally, to last beyond 10 years. And so certainly there are problems with them. And I think, luckily, in the majority of men, you know, are at that end where 10 years of use is probably okay, but it's certainly a consideration in younger men. They can be replaced. I mean, you can take one out and put another one back in, but what you can't do is take one out and go back to how you were before, you know, so that's it. In terms of complexity, though, I think they're now pretty much uniform, what are called three-part devices. And they come basically the two corpora cavernosa, which are the sort of inflatable balloons that when we get an erection that are inflated by our circulation, are replaced by these bags, if you like, that are extended into the penis, both into the abdomen and into the penis. Hanging in the scrotum, you have a pump like a third testicle, and you have a reservoir of fluid up internally beside the bladder. So men somehow think that this is visible from the outside, and one of the advantages of this is all internal, so nobody actually knows that the man has got an implant, and you know he's not walking around with a permanent erection, and it's inflatable, which means that it's not erect all the time. When he wants an erection, he'll pump the pump like that, and this will inflate these to there's some rigidity there, and the fluid is transferred therefore into the cylinders. And then when he's finished, there's a little valve on the side here which breaks the valve, and the fluid then goes back. So he then goes back down again, and he can keep it up for as long or a shorter period of time as he wants. So, you know, the idea is, again, a bit like injections. It's scary, but with adequate explanation and so on, it's an acceptable form of treatment. My philosophy has always been, and why I work in the field, is that I think sex and sexual problems is really important, and I think it's important as an individual, it's important in the context of a couple. All the evidence from medical students about wanting to be taught about sexual function and dysfunction, and from patients in all different cultures about asking about and helping with sexual problems, shows that we, the doctors, don't ask enough and don't offer enough treatment. And you're absolutely right, there are barriers to that in terms of language, culture, and when I'm teaching doctors here, I'll try and demonstrate how I may bring up the subject or discuss it in slightly different ways for different types of patients. You know, you've got quite a formal, stiff upper lip, sort of English type of 70-year-old, for example, versus knocker Aussie minor, 35 covered in tattoos. The way you approach the problem has to be different. And I think if there are cultural difficulties as well about how you approach it, it's the same as any other aspect of medicine. You have to suspend your own personal beliefs and be non-judgmental and open in your answering of questions and asking of questions.
And our thanks once again to all of our guests, Dr. Chris Judkins, Dr. Steve Adams, Dr. Jeff Thavasilan, and Jan Bain for their time and expertise. Now remember, this program and all of our programs are allocated CPD points through both RACGP and ACRIM. You can download your feedback and attendance sheet from the Rural Health West website, or simply follow the links and complete the online feedback form to be eligible. We're back on the 1st of April, and that's no joke. We'll have a program looking at developmental pediatrics. We look forward to your company then. For now, I'm Jerry Gannon. Thanks for watching.